Okay, so good evening to one and all, and thank you once again for joining this lecture. And today's topic will be on cervical spine injuries. So we have 33 vertebrae. So if you include the fused ones as well, and we have seven cervical ones, and these are perhaps the most important one of those 33 vertebrae. So when you talk about cervical vertebra, you have typical cervical vertebrae and you have atypical cervical vertebrae. So typical are basically this C3 to C6 vertebrae, and your C1, C2, and C7 are actually known as your atypical cervical vertebrae. So the basic anatomy of the cervical spine compared to the other vertebrae is that the vertebral bodies are relatively smaller and the vertebral foramens are relatively larger compared to the other vertebrae lower down. There is a special feature here called foramen transverse area. And the job of this thing is to transmit your vertebral arteries on both sides. So this is very important in trauma as well, because fractures involving the foramen transverse area can lead to vertebral artery injuries, and that is an indication for CT angio of the head. Another cool feature of the cervical vertebra is the bifid spinous processes. So this is a side-on view of the vertebra. So you can see the vertebral body. The multiple bones here are actually overlapping. So you might not actually be able to make it out very clearly. So this is important because we generally look at this sagittal view a lot while reading CT scans of the C-spine. So we have a lot of bones overlapping here, the transverse processes, superior inferior articular processes, etc. The and behind we have this spinous processes as well. So another important thing I forgot to mention is that when you're talking about the general anatomy of any vertebra for that matter, you have a vertebral body, you have a pedicle which is more anterior, and you have a lamina which is thinner and more posterior, and in between you have a transverse processes and your superior and inferior articular faces, and in behind you have a spinous processes. So if you're going to understand these injuries of the cervical spine, you have to understand the basic anatomy of a cervical vertebra. Otherwise this will all become very confusing very soon. So coming on to the atypical vertebra. So first one is the C1. C1 is atypical because it's basically a ring. So you have an anterior arch, a posterior arch here, and lateral masses with your transverse foramen also. So there is no body of this for C1, and there is no spinous process for C1. So the second atypical vertebrae is the C2. Again, very hard to miss this on a CTC spine, because we have a big prominent thing coming up from the center of this vertebra called your dens or your addendum process projecting up. So that is the main important thing with regards to your C2. And your C7 is atypical because it's basically a transition vertebra. You're going from the cervical spine into the thoracic spine. So uh, the spinous processes are no longer bifid here, and your transverse foramen in C7 usually does not transmit your vertebral artery. Now, the important joints that you have to be aware of are your atlanto-occipital joints and your atlanto-axial joints. So basically between your C1 and your occipital condyles and your C1 and your C2. And there are a lot of important ligaments that are actually connecting these two joints. The exact details are perhaps not needed, but it is important to recognize that in ligamentous injuries to this level, you can have uh, displacement of your normal bony structures. For example, there's something called Powers ratio. So Powers ratio is basically you are looking at a ratio between this A to O and B to C. So you're basically looking at the CTC spine from a sagittal view, and so the ring of the C1 is actually you're cut into two parts. So you're releasing 2 points of the C1. So you have an anterior arch of C1 and a posterior arch of C1. So going from the anterior arch of C1 to the posterior to the opistheon, and from the posterior arch of C1 anterior to the basior. So normally AO is more than BC. So basically what you are understanding is that AO is always going to be more than BC normally. Now if the BC is going to distance is going to become bigger and bigger and is almost equal or more than the AO distance, that is when you start suspecting the atlanto-occipital dislocations. And we'll come into that more when we talk about the radiology. Now, cervical spine, why is it important? Because when you're talking about blunt polytrauma, it's about 5 to 10% of all total cases end up having injuries to the cervical spine. So if you are working at trauma center, you'll be knowing that we're getting hundreds of RTA cases every day and other types of blunt trauma cases. So if you are having a lackadaisical approach to the cervical spine, you're going to be missing around 5 to 10 cases per hundred. That means multiple cases per day. That is why it's important to actually have decision-making rules that can help you to avoid missing cervical spine injuries. And if you look at all spinal cord injuries, more than half of them, 55% of them, tend to affect their cervical spine only. So coming to pathophysiology, I'm not going to go into great detail here, but basically you have primary injury of the spinal cord and secondary injury of the spinal cord. This is similar to the primary and secondary traumatic brain injury, and our basic goal is to provide good treatment here and prevent the secondary injury, similar to TBIs. Because primary injury is basically the mechanical trauma to the spinal cord, which you cannot actually prevent once the patient actually presents to you. Secondary injury is basically your cellular level changes like microhemorrhages, microtrauma in the spinal cord that is basically propagating the damage, and that is something that we would like to prevent as the treating physicians. Now, there is something called the Dennis three-column theory, very, very famous, but although it is generally going a bit out of favor for something else, which we'll get into. So, usual the concept about the Dennis three-column is that we have three columns of the spinal cord. You have an anterior column, a middle column, and a posterior column. Your anterior column is basically anterior to two-thirds of the vertebral body, the intervertebral disc, and their anterior longitudinal ligament. Middle column is basically the posterior part of that. The posterior one-third of the vertebral body, intervertebral disc, and the posterior longitudinal ligament. And your posterior column is basically your posterior elements that we spoke about earlier in your anatomy section. Basically, your pedicles, facets, lamina, spinous process, etc. And as well as the various posterior ligaments. Now, if two out of the three columns are affected, then it is unstable as per the Dennis three-column theory. Now, the problem here is that all of these three columns are not created equal, and there is one column that is more important than the other two, that is your posterior column. So, posterior columns, if involved, are generally serious, and that might be a consideration for whether to go for surgery or not. So, the most important column is actually the posterior column, and if that is involved, then that is a huge problem. So there is a very confusing table in Tendinali about your classification of cervical spine injuries based on mechanism. So basically, based on mechanism, whether your C spine goes this way or that way, or maybe a combination of rotation or something. We have flexion-based injuries, flexion rotation-based injuries, extension injuries, and vertical compression injuries. So the most common type of mechanism is going to be flexion type of mechanism. So most of these fractures are due to flexion type injuries. So you have a wedge fracture, flexion teardrop fracture, Clay-Shawler fracture, bilateral fascial dislocation, and your atlanto-occipital and axial dislocation, and adenoidal fractures. Among these, the important unstable injuries are the flexion teardrop fracture, the bilateral facet dislocation, unilateral can be stable. Atlanto-occipital dislocation, obviously, all of those dislocations are going to be very, very serious, and especially your adenoid fracture, especially type 2 adenoid fracture, which will come to little shortly. So these flexion injuries, basically, what you have to know is that you can have uh, flexion teardrop injuries. Flexion teardrop injury are usually the anterior inferior part of your vertebral body. And one thing you have to remember is that looks almost exactly the same as an extension teardrop fracture as well. Only thing is that extension teardrop fractures are basically due to avulsion of that particular segment, whereas flexion teardrop is basically due to a combination of flexion as well as compression from up to down. So that is why this happens in flexion teardrop. Then other things like facial dislocation, it can be unilateral, it can be bilateral. How do you differentiate between unilateral and bilateral facial dislocation? Unilateral, the dis, the translation of one vertebra over the other usually is going to be less than 50% of the vertebral body, whereas in bilateral cases it can be more than 50%. So that is how you have how you can differentiate between unilateral and bilateral facet dislocations. Coming to simple and unstable wedge fractures. So usually wedge fractures involve the anterior part of the vertebral body. If your wedge fracture also involves your posterior elements, leading to widening of the space between your spinal processes, that is an unstable wedge fracture. So these are some of the injuries that you have to be familiar with, and we'll discuss them more in the radiology section. So so that is all about flexion. Sometimes you can have a combination of flexion as well as rotation injuries, and that is a classic example for a rotatory, sorry, unilateral facet dislocation, because generally facet dislocation unilateral tends to have some component of rotation as well. Then extension type injuries, less in number, but all of them are unstable. So your C1 fracture, your Jefferson fracture, sorry, your posterior arch, the C1 fracture, the hangman fracture, extension teardrop fracture, and your posterior axial dislocation. All of these are unstable. So hangman fracture is basically a fracture of C2 and is involving the parts of C2. So this is where it fractures. Extension teardrop almost looks very similar to flexion teardrop, but this is more of an avulsion fracture as you see here. And so these are some of the important extension type injuries that you have to be familiar with. Vertical compression, Jefferson fracture. So this is basically due to vertical compression directly on top of the head. So you can have breaks in the anterior and posterior part of the arches of your C1. So that is a Jefferson fracture that is can be unstable. So again, the crutch of it that you look for unstable injuries. So if there is gross translation and of one vertebra over the other and spinal canal compromise, that is obviously unstable. Fractures that tend to be unstable always are bilateral facet dislocation, flexion teardrop fracture, and wedge fractures if they have posterior ligamentous rupture also. Odondor fractures, hangman fractures, extension teardrop fractures are other types of unstable fractures, and vertical compression can lead to Jefferson fractures, which can also be unstable. So coming on to clinical history, so how how do you consider whether a patient based on his or her mechanism of injury is going to be at high risk of cervical spine injuries or not, or whether the patient is having a low enough risk that you can proceed without radiology. So the risk factors include if a patient is falling more than 10 feet height, or a motor vehicle accident at significant speed. So different sources give different speeds, so this can be a little bit difficult to follow in practical terms. Some say 35 miles per hour, some say something else, but basically high speed motor vehicle accident is always going to be a dangerous mechanism. Any kind of paresthesias or weakness in any of the limbs, any type of altered sensorium. So any kind of patient who is altered, you cannot clear the cervical spine without imaging. Any kind of altered sensorium, you cannot clear the cervical spine without imaging. Very important to understand. Then obviously, if you have Other features of bowel or bladder symptoms of priapism, that is obviously going to make you think of some kind of spinal cord issue in the context of trauma. So, what is the problem with high cervical spine injuries above C5? Then you're starting to get diaphragmatic paralysis, can lead to shortness of breath, and then you get abdominal pattern of breathing as well. And higher the level, that tends to lead to all kinds of autonomic instability as well. And why that happens will come into a little bit later on. So one useful thing that you can do at the bedside in this kind of patient to see if the patient is going into some kind of respiratory failure is to look at the single breath count. And this is most useful if it is done serially. So if your patient on arrival had a single breath count of 28 and around 8 hours later is having single breath count of 12, that patient is not going in a right direction. So generally speaking, if a patient is having SPC of less than 15, that is generally when we start considering the patient for intubation. Now, coming to the physical examination, see, most important is you're looking for neurological deficits, and you also document the neurological deficits, because it's important for people to understand what the deficits were when the patients arrived, and what the deficits were later on. Generally, your goal here when you're managing cervical spine injury is to make sure that once the patient actually arrives at your center, patient is not developing new defects. So for that you'll have something called Asia classification, which we'll get into here. But general what we look for is to look for the level of injury, look for any saddle anesthesia, make sure you do a peripheral examination and look for any anal tone. Obviously, you're going to examine the entire cervical spine by doing a log roll, and you can look at certain reflexes like bulbocavernosus reflex as well. Now, there are certain syndromes of the spinal cord that you have to be aware of. You have anterior cord syndrome, central cord syndrome, Brown's cord syndrome. So, if you're talking about anterior cord syndrome, so again, I told you flexion type of injury generally tend to involve the anterior part of your vertebral body and all. So, it will lead to anterior cord compression if it is severe. That can lead to anterior cord syndrome. And if you remember what are the things present in the anterior part of the cord, you'll know that most of your motor fibers are there, as well as your spinal thalamic tract. So all of those will be affected, and there'll be gross weakness below that particular level. Your posterior columns, in comparison, will be normal. So your vibration proprioception will be normal, because that is located more posteriorly. Central cord syndrome, on the other hand, is due to hyperextension injury. So all of the hyperextension injury that I mentioned earlier can lead to central cord syndrome. And what you have to remember here is that your fibers for your upper limb are located more medially in the spinal cord than your lower limb. So your upper limb tends to be affected more than the lower limb when it comes to your central cord syndrome. And hemisection of the spinal cord, Brown's cord, usually in the context of trauma, it should be due to some kind of direct stab wound to the spinal cord. So it can lead to ipsilateral paralysis and contralateral loss of the spinal thalamic. So ipsilateral motor fibers and your posterior columns and contralateral spinothalamics will be affected in Brown's cord. One terminology that you have to be familiar with is the difference between neurogenic shock and spinal shock. These are not the same things, even though they have shock in the word. So neurogenic shock is basically a type of distributive shock that actually leads to bradycardia and hypotension, whereas spinal shock is basically the initial stages of spinal cord injury, where there is a temporary loss of spinal activity below the level of injury. And this by definition is not a type of hemodynamic shock. So now there is a classification that will help you look at how severe a spinal cord injury is. That is called your Asia classification. So in order to do an Asia classification, you have to do various things. One is you look for a sensory level on the right side and the left side, motor level on the right side and the left side. calculate the neurologic level of injury. I'll tell you how that is done. And then you comment on whether it is a complete or an incomplete injury. So sensory level, motor level, find the neurological level of injury. Is a injury complete or incomplete? So these are the four questions that you have to answer while you're doing the Asia classification. And this is the form for doing the Asia classification. So you have in your center here, you have a dermatome drawn here. So you'll have an idea about where to test all of these things. So in the middle here, you have point sensory examination both on the right side as well as your left side. So and this is divided into both your light touch and as well as your pinprick. So light touch is for your posterior column, pinprick is going to be for your spinal thalamic, and this is going to be graded as 0, 1, and 2. 0 is completely absent, 1 is anything other than what is normal, and 2 is normal. So very, very easy. So sensory examination, you are going to be labeling all of this area as 0, 1, and 2. So, and you will do that on both sides. You'll do that on both sides. So what first question is what is going to be your sensory level on the right? So it is going to be the lowest level, which is actually normal for both light touch and pinprick. So lowest level, which is having two score of two on for both light touch and pinprick. If you have two on one side and zero on the other side, that is not going to be your sensory level. You have to go for the one above that, one which is normal. So that is a sensory level, and you look at it on both sides. So it could be that the sensory level on this right side is C5 and on the left side is C6. So you can have variations like that. Coming to motor part, you have a certain muscle groups which are tested to look at various nerve levels. So for C5, it is elbow flexion. C6 is wrist extension. C7 is elbow extension. C8 is finger flexion, and T1 is finger abduction. So you are going to be testing both of these on the same side, and you're going to be using the usual muscle grading that you use from 0 to 5 that we all learned in MBBS. For lower limb, it is L2 to S1. So hip flexion is L2, knee extension is L3, ankle dorsiflexion is L4, big toe extension is L5, and ankle plantar flexion is S1. So again, you're going to be you're going to be documenting the muscle power grade of each one of these. Now the question is, how do you calculate the how do you calculate the motor level of injury? So it it is going to be usually the level which is having at least 3 by 5 muscle strength. But if you will only count 3 by 5 muscle strength as your motor level if the level above that is having normal 5 by 5 power. So if you have if you have, for example, if you have C7 which is having five of no, power of 5, and C8 is having a power of 2, and there's nothing present below that, then the level is going to be C7, not C8. But if you have power of 5 in C7 and 3 in C8, then their motor level is going to be C8. So that I hope that is clear. So this can be a little bit confusing. So that is why I'm actually taking some time to explain this. So based on that, based on your sensory and the motor level, then you calculate the neurological level of injury, which is the lowest segment with at least 3 by 5 power. That is anti gravity muscle strength and normal sensation. So it has to be having at least 3 by 5 muscle strength and 2 out of 2 uh, sensation. So that will give you a neurological level of injury. And then importantly, you all have to consider whether it is complete or incomplete injury. So for complete or incomplete injury, you will have to look at three things and only three things. One is voluntary anal contraction, deep anal pressure, and S4, S5 sensations, perianal sensations. If these three things are absent, that is a complete injury. As simple as that. So if you're doing a peritoneal examination, your patient is not able to voluntary contract the anus, not able to feel deep anal pressure, and S4, S5 sensations are absent, that is a complete injury. Okay. So I think that is where we'll stop here. So based on this thing, we'll have classification into A to C. A is easiest because it is complete injury. So what we defined as complete injury, absence of VAC, DAP, and S4, S5 sensation. So B and C, B is sensory incomplete. So what do you mean by sensory incomplete? There is some motor there is some sensory function below the neurological level of injury. And basically, if there is no motor function more than three levels below the neurological level of injury on either side, that is Asia B. So if you're having a neurological level of C6 and there is no there is no activity from sorry, if suppose if it is your level is C5 and you have no motor activity from T1 below, then that will count as Asia B. So Asia C and D is basically going to be based on the individual's muscle group strengths that we discussed about. If more than 50% of your muscles are having power more than or equal to 3, that will count as Asia D. And if less than 50% are involved, that is counting as Asia D. And E is normal, and you will only call it Asia E if there is some history of suggestion of spinal cord injury. That is when you call as Asia E, or history or radiological evidence of spinal cord injury. So A is complete, very bad. Asia E is basically normal, and everything else is in between, B, C, and D. So there's something called zone of partial perturbation. I'm not going to detail of this. Basically, below the neurological injury, any level with some kind of activity, the lowest level with any kind of activity, that is your zone of partial preservation. That can help in some of the prognosticating these injuries. So coming to decision-making rules, very, very, very important. So you have something called nexus criteria. Nexus criteria is basically things that we look for to rule out the need for cervical spine imaging. Is it specific? No. Only 12% specific. Is it sensitive? Yes, 99% sensitive. Very high negative predictive value. But the important thing is that you have to actually apply this rule appropriately. If you apply this rule in a wrong manner, then you are likely to actually miss injuries. So, what is actually included in the necessary criteria? There should be no focal neurological deficit, which might be the easiest part of this because most of us will be looking for neurological deficits most of the time. No evidence of intoxication, no painful, distracting injuries, normal level of alertness and consciousness, and no midline cervical tenderness. So this is the fine print of all of these things. Most of those, including ATLS, only mentioned the actual this thing, one liner of the different points. But there are some things you ought to be aware of. What do you mean by intoxicated? As per this thing, intoxicated is not just abnormal behavior. Even smell of alcohol on the patient, that is included as intoxicated. Ortal sensorium, as per this thing, does not mean that you're only going to be looking at GCS. GCS of 15 doesn't necessarily rule out on nexus. You also has to be completely oriented to time, place, and person. Some things obviously you are not going to be doing in the medicine in most of the places, like trying to remember three objects in 5 minutes or anything. But please remember this: it's not just your okay. Patient is M6 C-spine clear. That is not really how it works. The patient has to be fully oriented to actually rule out. And the most difficult thing to define here is your painful distracting injuries. There's no clear definition of exactly what that is. That can be a long bone fracture, that can be a crush injury, that can be a degloving injury, that can be major burns to the body. All of all of these things are considered at painful distracting injuries. So you have to remember that, for example, massive crush injury of the lower limb, that doesn't really rule out your cervical spine, even if it doesn't feel that way clinically. So there is another criteria called Canadian C-spine rule, which is little bit more specific compared to your nexus. So basically, the basic construct of this Canadian C-spine rule is that first you look for any risk factors. If you have risk factors, you do imaging. If you don't have risk factors, then you look for any low risk factors. Things that make it likely that it is unlikely that patient is going to be having any serious injuries. So if you have any low risk factors, then you look for ability to rotate the neck, and you will not do this. You make the patient do it. Rotate it 45 degrees, left and right. If the patient is able to do that as well, then your C spine is cleared and you do not need radiography. So what are the risk factors I mentioned here? Age more than 65, any kind of dangerous mechanism, paralysis in the limbs. If any are present, you have to go for radiology. And as per Canadian C-spine rule, again, this is why it can be a little bit frustrated to read about mechanisms of injury and trauma, because every criteria has some kind of different definition for what counts as a dangerous mechanism. But basically, adults more than 20 feet, kids more than 10 feet or more than three times their height. That is for falls. What about motor vehicle crashes? Intrusion more than 18 inches on any side or more than 12 inches on your occupant side. I don't know how they actually measure that, to be honest. Ejection from the vehicle, always dangerous. Passenger death, always dangerous. And those patients are always triaged red, no matter what, no matter how well they see. Motor vehicle versus a pedestrian or bicycle. So bicycle or pedestrian getting hit by a motor vehicle, always dangerous. And crash more than 20 miles per hour, as far as Canada's C-spine rule goes. So these are counting as dangerous mechanism of injury, and these are where C-spine imaging is indicated. So what are the low risk factors? So if you have any of these low risk factors, you can proceed to the neck motion part. So low risk factors are simple rear and MVC. Patient is in a sitting position in the ED, ambulatory at any time, or a delayed onset of neck pain. Delayed onset more likely to be some kind of muscular pain, and absence of any midline cervical spine tenderness. If any single one of these are low risk factors are present, then you can move on to the last part of which is able to rotating the neck 45 degrees to right and left. And if patient is able to do that as well, the patient is clear as far as the cervical spine goes. Now, MCRIT and Scott Weingart did a podcast many years ago. I think it was 14 years ago, where he said that he likes to actually combine these two rules into one. Initially, he does the nexus rule. If any of the four are present, so intoxication, not oriented, any neurodeficits, or painful distracting injuries, then he will image, and he has included the parasitias as well here. So any of those are present, then you have to image. There's no question about that, and I don't think people are missing those kind of things as well. Problem he feels is that when you have midline tenderness, can be minor due to minor trauma as well. So if you are having midline tenderness, then you look for any of the low risk criteria that we mentioned. And this is only applicable if you have no dangerous mechanism. So if low risk criteria are present and no dangerous mechanism, then you go for the neck rotation, and you can, if that is normal, then the patient is cleared. So if and again, if your nexus is completely negative, again you ask the patient to rotate the neck, and if it is clear, then you can stop. But if anywhere it is abnormal, then you go for radiography. Now the disclaimer here is that there is no actual study looking at combining nexus and your connecting C-spine roots. Its logic is that by combining both roots, you'll actually be able to image less people. So it's something to think about. That is why I have included it here. So pediatric C-spine, little bit different compared to adults. So risk factors, some of them are same. AMS, FNDs, high risk MVCs, neck pain, etc. There are some things that are particular for C-spine injuries in peds. For example, torticollis, one of the signs of a C-spine injury in pediatrics, diving, and any predisposing factor for spinal cord injuries. For example, Down syndrome patient, you have to be very, very careful about spinal cord injuries in these kind of patients. So coming to imaging, even though I mentioned the X-ray here, most of the time X-rays are not the definitive way to clear the C-spine. Why? Because the sensitivity of an X-ray of the cervical spine for cervical spine injuries is around 45%. 45%. So unfortunately, that is not good enough, and that pales in comparison to the sensitivity of a CT scan. Even though CT scan also is not 100% perfect or anything, but it's like much, much better than just doing a C-spine X-ray. And most of your apex trauma centers have actually moved away from your X-rays of the C-spine and moved on into your CT scans of their cervical spine. So the problem is that if you're looking at X-rays of the C-spine, it has to be adequate. Adequate means it has to image everything from your C1 up to your T1 vertebrae. Everything has to be visible on the X-ray to actually comment something. And even then, it will be difficult to rule out, because again, you are only seeing it in really in one plane. So as we learn when you go into CT, you have to look at it in three planes ideally: sagittal, axial, as well as coronal, to actually do a proper evaluation of the cervical spine, especially in severe trauma. So you can have normal C-spine and AP and lateral views, and you have an open mouth view specifically to look at your dens. Dens as well as your lateral masses of the C1. If you to call this adequate, all of these structures have to be visible. And again, even if it is visible, sometimes the fracture line can be very, very subtle. So that is again a big problem with relying on radiology. Now coming to reading X-rays as well as to some degree CT spine, there is a mnemonic that will help you, which is ABCDS. So A is again for adequacy. It has to go from a skull base to the top of T1. And if you're doing an open mouth view, it has to show your addendum process and the lateral muscles of C1. So again, and second is for alignment. You have an anterior vertebral line, anterior part of the vertebral bodies, posterior vertebral, spinal laminar line, and posterior spinous line. So anterior vertebral line, anterior part of the vertebral bodies, posterior vertebral line, posterior part of the vertebral bodies, spinal laminar line between junction between the spinous process and the lamina, as well as the tip of the spinous processes. All of these lines usually form a smooth arc. If the smooth arc is not being formed and one vertebra seems to be jumping out compared to the rest, that is definitely abnormal. So that is something to remember. BCD, B for bones, look for any obvious fractures, compression, loss of height, etc. Disc space, usually now all are normal. So if you're having gross diminution of disc space, consider some kind of injury. Although to be frank, the most common cause of reduced disc space is going to be chronic degenerative disc disorders. Facet joints, Very difficult to examine on X-rays. Much better to be done on CT scans. And any widening or narrowing of the interspinal spaces. So that is also important. So coming to other D part, which is for dens, that is auditory process. We have type 1, type 2, and type 3 injury. Type 1 is the tip of the dens. Type 3 is basically the junction of the dens and the body. And type 3 is basically mainly through the body only. So the most unstable one of these is going to be your type 2. That is what you have to keep in mind. Soft tissue injuries, you have to remember a normal prevertebral soft tissue. So above around C3, it is going to be less than 6 or less than a third of your width of the vertebral bodies. We can remember it like that. So at C6, it's usually less than 22 in adults. So increase in your prevertebral soft tissue can be due to hematoma, and but this is generally more useful in cases of infections of the neck. It can also like your retropharyngeal abscesses and all, which can also lead to a widening of the prevertebral soft tissues. So again, Atlanta-occipital dislocation. What are some clues here? Again, I told you earlier, your distance from your anterior arch of the C1 to your opistheon in the left side image is less than your distance from your DCN to your posterior part of C1. That is never abnormal. This is Atlanta-occipital dislocation. Now, one clue that you can use to diagnose this thing is spinal cord EDH, which is highlighted with your blue arrow here. So spinal cord EDH, almost all of these Atlanta occipital dislocations are going to be associated with some degree of spinal cord EDH. So if you see this thing, then probably you're dealing with an Atlanta occipital dislocation. So if you have shown an X-ray here, so can somebody type out of what you think is abnormal here? You can type it out in the chat box, please. What do you think is abnormal in this C-spine X-ray? Okay, so you can see at the C3 C5 junction here is definitely abnormal here, and it is definitely alignment is problematic. C3 C5 alignment is abnormal here, and also more importantly, look at the distance between the spinal processes here. So you can see that there is a significant degree of widening of the spinal process at that particular level, and that usually indicates an unstable injury. So this was actually a facet dislocation, unilateral facet dislocation, and for facet dislocation, the best view to actually look for them is basically going to be your axial view. And axial view, you can see on the right side here, which is not labeled, you can have the normal hamburger sign of your facet joints. That is a normal thing. Whereas on the blue arrow is showing your abnormal inverted hamburger sign. So normal hamburger has been inverted. So this is abnormal. This indicates facet dislocation. This is unilateral facet dislocation. That is inverted hamburger sign. Again, something that you look for in CT. Again, very difficult to see this on a sagittal view. If you're only looking at sagittal views on your cervical spine, you'll tend to miss this. So always make sure that you look at multiple views when you're reading cervical spine CTs before clearing them. So yeah, that is unilateral facet dislocation. This is bilateral. Again, you can see that compared to unilateral that we saw here, there is more degree of translation here compared to the previous one. Again, you can see widening of the spinous processes, suggestive of ligamentous injury posteriorly. So again, in the red area, you can clearly see here that the facet is dislocated, and in axial, you can see the bilateral inverted hamburger sign. So this is bilateral facet dislocation, and this is an unstable injury. This is an unstable injury. What about MRI? I'm not going to go into great depth on the MRI part, but basically, what is going to be most important on MRI in spinal cord injuries is if there is hemorrhage or not. So most of the patients who get C-spine injury eventually will get an MRI here. So if there's hemorrhage in the spinal cord, usually the motor recovery is going to be poor. Non-hemorrhagic, on the other hand, has better chances of some degree of motor recovery. That you can see on the spinal cord or MRI here. So, non-hemorrhagic just edema is usually going to be higher signal on the MRI, whereas low signal within that high signal usually suggests hemorrhage. So the black thing here is hemorrhage, and that is usually having a very poor prognosis. So coming to management, pre-hospital, always important to put a rigid cervical collar. The soft cervical collars are going to be completely useless here. That doesn't actually restrict any motion. So where this is not required is if a completely neurologically intact patient with a isolated penetrating neck injury, you do not put a cervical collar in that patient. So penetrating neck injury, isolated, neurologically intact, you don't put a C collar in that patient. So what if you need to intubate the patient? What is important is that you have to put the patient in manual inline stabilization. You do not intubate the patient with a C collar in position. That is a great why, because intubating with the C collar in position actually leads to more movement of your cervical spine compared to giving manual inline stabilization as per cadaveric studies. So that is why it's recommended to when you're intubating, just remove the C-spine and you give make your assistant give manual inline stabilization while you're intubating. So coming to neurogenic shock, why this happens? It happens in complete injuries above the level of T6 because your sympathetic supply usually come from T1 to T6. So complete injuries above T6. Complete injury, almost 90% of them will have neurogenic shock. The rate of neurogenic shock is going to be less when you have incomplete injuries. And this usually tends to occur in the first 2 weeks of the injury. So usually what we do is you have to start vasopressors. Usually it will present with bradycardia and hypotension. But you have to remember that in any patient with hypotension in trauma, you're going to be assumed that it is due to hemorrhage until proven otherwise. So always err on the side of over-diagnosing potential hemorrhagic shock rather than trying to fixate on neurogenic shock as the cause of the patient's hypertension. So sometimes the patient can have hyperactivity because sympathetic are cut off. You can have vagal hyperactivity leading to significant bradycardia, and sometimes you might need to add atropine as well to your vasopressors. So the target of MAP is going to be somewhat different to the MAPs used target in sepsis patient. The target range, they're given a range to target because they feel that targeting a single map all the time might not be so feasible. So as far as the latest criteria goes, they're given a range anywhere between 70 to 80 map to 90 to 95 map, and you maintain this for 3 to 7 days of treatment. So that is your target map for neurogenic shocks. There has been some two studies that have shown benefit with this approach of having a higher map of at least above 85. That is why they have given this range or lower end to a higher end range for neurogenic shock. So, to we are going to conclude this lecture too. So basically, you need to have a high index of suspicion for C-spine injuries, and you have to use your rule out criteria appropriately. So if you're not applying the nexus criteria as it was intended, and the kinetic C-spine rule as it was intended, then you might be missing a lot of injuries. You have to have a basic idea about how to read cervical spine X-rays and CT scan. You have to have some idea about how to do a Asia classification of spinal cord injuries. Is it absolutely essential for an emergency physician to know an Asia classification? Probably not, to be honest. If you're in a very, very busy shift, so you'll basically be looking whether this is Asia E or Asia A or something in between. Exact differentiating but that is not a priority all of the time. But it is good to have some kind of documentation especially early on, so that the patient can be monitored more easily later. And when you're having shock, even in C-spine injuries, always consider a hemorrhagic shock before you focus in on neurogenic shock. So we are going to stop here, and I'll be giving it over to Arvind sir to take over the rest of the topic. So, because one thing that I didn't mention is the role of steroids in spinal cord injury, and I'll leave it to other Arvind sir to discuss that part. So, sir, you can start.
Yeah, thanks, Neil.